concentration of riboflavin into the stroma. This is followed by a 6-minute soak of the Paracel 2, giving a total soak time of 10 minutes. So this is the UVA irradiation, which is delivered in a central 4 mm zone using the pulsed approach of 1 second on to 1 second off, and a total fluence of 15 joules per centimeter square. The mask that you can see here was essentially to deliver the oxygen, and we had a concentration of more than 95% throughout the UVA irradiation. So what were our results? You can see that both in terms of the change in MRSE and the keratometric flattening, our results were superior to the previous studies, even the eyes with the epi-off approach. The refractive change starts as early as 1 week and continues till about 3 months, where it stabilizes. So this is a graph which shows the change in the uncorrected distance visual acuity in our cohort, where you can see at about 3 months, 73.8% of the eyes had an unaided vision of 6 by 7.5 or better. This is the haze that is seen on the immediate postoperative period and the resolution at 1 week. On the anterior segment OCT, you can see a central demarcation line in the 4 mm zone, which is essentially where you delivered the fluence. So you can see on keratometry, there is a well circumscribed central flattening with a change in 1.25 diopters of SWIA for the patient. She was 20/20 unaided at 3 months. So was the flattening greater in weaker corneas? Well, the answer is no. We did not find any changes between the refractive correction and the corneal biomechanic index. However, this data was derived using the Corvis, which is not the most precise tool. So till such time we can use in vivo biomechanics using the Brillion, the result will still remain, the question will still remain unanswered. In conclusion, Pixel would be offers promising results and would be the modality of treatment in patients with post-LASIK regression and patients who can otherwise not undergo the conventional keratoablative procedures for refractive correction. Thank you.
Thank you, Gitansha. So in essence, basically what we are doing with this customized platform is in keratoconus, basically we are trying to deliver a greater amount of energy over the cone with progressively decreasing energy in selective areas, so that in the hope that we induce a greater selective flattening over the cone with a better topographic and refractive outcome. In Pixel, even though it's the same machine which is being used, it's a circumscribed central energy in the central 3 mm zone, and which causes a central area of flattening, which helps in correcting this low grade of myopia. So any questions that you may have about these two procedures? Fine. Thank you. So we'll then move on to Dr. Shreesha Kumar's topic. Dr. Shreesha Kumar is a senior cornea consultant at the Eye Foundation, Coimbatore, and he'll be addressing the complications of cross-linking and management.
Good afternoon, everybody. At the outset, I would like to thank Shreyas for including me in this session. My topic is on complications of CXL and its management. We have heard lots about the advances in CXL by the previous speakers, but it has its own limitations also. It's been described as a long-term or short-term complications by various authors, and it could be a primary or a direct complication due to the procedure itself, or it could be secondary due to the BCL or epithelial defect which we create, or due to steroid usage post-operatively. So, what are the complications we can encounter following CXL? Mainly it's the infectious keratitis or sterile ulcers, corneal melts, corneal haze, endothelial damage, or treatment failure of CXL. These are some of the common complications, even though they are rare, which we encounter following CXL. Infectious keratitis, one of the dreaded complications. We don't want this to happen in a patient, a young patient, and it can be devastating, highly sight-threatening. It can be because of the epithelial debridement which we create, or due to bandage contact lens or poor hygiene, especially in pediatric patients, and following use of topical steroids. These causes or risk factors can be divided into preoperative risk factors, intraoperative and postoperative risk factors. If the patient has a poor lid hygiene due to blepharitis or MGD or lid margin abnormalities, the patient can end up having infectious keratitis. Or a patient who is a chronic VKC patient or a AKC patient, atopic keratoconjunctivitis patient whose corneal surface is abnormal can catch infectious keratitis following CXL. And intraoperative reasons or etiological agents could be because of the creation of epithelial defect and prolonged exposure of UVA, contamination of the solutions, irrigating solutions or riboflavin which we use can lead to infectious keratitis. Post-operatively, it is mainly the bandage contact lens which we have for 3 to 4 days, or post-operative usage of steroids which can cause infectious keratitis. The common microbial profile is the organisms which are present in the ocular surface flora, and Staphylococcus aureus is the commonest organism which was isolated in patients with infectious keratitis following CXL, followed by Streptococcus, Pseudomonas, E. coli, and there has been reports of herpes virus reactivation and one odd case of acanthamoeba keratitis following CXL, and fungus or mycobacteria can affect the eye. So there has been reports on microbial keratitis following accelerated collagen cross-linking. This was a recent article by RP Center. They have described 7 cases of infectious keratitis following accelerated collagen cross-linking. And there has been reports of reactivation of herpetic keratitis following CXL. It's been found that UVA light is a potent stimulus for reactivation of this herpes virus, and if there is a significant trauma due to epithelial defect which we create, or the damage which occurs because of the irradiation to the stroma, or damage to the nerves, can cause reactivation of herpetic keratitis. This is one of our case. This particular patient developed a central corneal ulcer on day 3, and this is one of our first few cases of complication of accelerated CXL. And this particular patient had a staphylococcal keratitis. The organism isolated was Staph aureus, and he responded very well to the treatment of moxifloxacin and tobramycin combination, topical, and the ulcer is completely resolved with the leaving a nebulomacular opacity right in the center. The patient had improved to 6-9 parts, and this was since it was the first report of complication in accelerated cross-linking. It was published in OJO. Another case of fungal keratitis which responded well to antifungal treatment. There have been reports of sterile keratitis following cross-linking, and it's been found that there is an exaggerated healing response in a cross-linked cornea, and there has been a increased keratocyte death and a gradual repopulation, and it increases the scarring response in these cross-linked corneas. And the one more reason for sterile infiltrates is mismatch between the base curve of your contact lens and the corneal curvature, which if there is a steep which can accumulate, which can cause pooling of tears between the contact lens and the cornea, and this staphylococcal antigen which is present in the ocular surface can accumulate in this pooled tear and can cause either a sterile reaction or infective reaction by penetrating into the stroma of the cornea. These are some of the examples of our own cases. This particular patient developed this kind of picture after 3 days of cross-linking, and is an accelerated cross-linking. We have used 9 milliwatts for 10 minutes, and this particular patient comes back with severe photophobia, irritation, watering, and we found these are all deep infiltrates, but they responded very well to topical steroids and antibiotic and tear substitutes, and this is a 1 month follow-up picture. Another similar case, you can see multiple infiltrates in the peripheral, mid-peripheral cornea. This is the area, the junction between deepithelialized and epithelialized cornea of this particular patient, and most of these sterile reactions, they develop at the junction of epithelial defect and the normal cornea. And this particular patient also responded very well to topical steroids. This is a rare case. This particular patient had a combination of CXL with intacs for a decentered cone, and on day 3 the patient comes back to us with severe pain, irritation, photophobia and watering, and on examination we could see a hypopia of 1 millimeter, and there are 2 infiltrates on the surface, thin infiltrates, not very dense infiltrates, and we did all the microbiological examinations, and we scraped the cornea, even though we could not get much material from the lesion, and but KOH staining showed fungal filaments, but we sent material even for culture and sensitivity. Since there was some filaments seen on KOH, we started this patient on antifungal agents, but patient comes back after 3 days with increased symptoms and signs. Hypopia has slightly increased. By then we received the culture report, there was no fungus, so we started treating this patient as a sterile infiltrate and started on steroids, and the patient responded well. This is 1 month